Of all members of the TPN team, it is the nurse who is in most frequent contact with the patient, who does routine patient monitoring, who changes the dressings, the infusions, and the tubing regularly, and who is most likely to first encounter potential problems. Baseline and routine monitoring is important for initial nutritional assessment and for identifying potentially hazardous changes in laboratory values so that they can be corrected before clinical problems arise. In order to monitor the patient's status, it is important that comprehensive baseline studies be obtained prior to the start of TPN therapy. Then at specific intervals during therapy, certain laboratory tests are repeated to monitor the body's response to the therapy. Although baseline laboratory tests vary according to institutional protocol, certain tests are always indicated. These include complete blood count, serum electrolytes, urea, creatinine, bilirubin, liver enzymes, total protein, albumin, glucose, calcium, phosphorus, magnesium, triglycerides. Additional baseline data of critical importance are body weight and intake and output. During the first 5 to 7 days of therapy, daily monitoring is done of body weight, intake and output, nitrogen balance, serum electrolytes, and blood glucose to determine the body's ability to adjust to the TPN solution. Solutions used in TPN contain high concentrations of essential nutrients. It is necessary to administer them slowly and increase them gradually to give the body time to adapt to the increased glucose concentration and to the osmolality of the solution. Biochemical responses of the body are carefully monitored by means of laboratory tests during this period of adjustment. One of the most important tests is blood glucose, since the body's ability to handle large glucose loads varies greatly from patient to patient. Glucose monitoring is most often done every 6 hours by finger sticks, with a confirming lab test done periodically. Administration of hypertonic dextrose solution, such as that used for TPN, always triggers a corresponding shift in electrolyte balance. Other shifts of electrolytes involve phosphate, potassium, sodium, and chloride ions entering into active tissue synthesis. Because these shifts may cause a serious electrolyte imbalance, daily monitoring of sodium, potassium, phosphate, and chloride is needed during the period of stabilization and is continued on a twice-weekly basis thereafter. Biochemical responses to proteins and lipids are less abrupt than those involved with glucose and electrolytes. Weekly blood and urine tests for BUN, ammonia, and albumin are good indicators of protein tolerance, while weekly serum triglycerides effectively monitor lipid tolerance. Monitoring of weight, intake and output, and blood glucose continue to be done daily throughout the course of TPN therapy. The therapeutic effect of TPN is most easily judged by the patient's ability to gain or to maintain weight. Thus, an accurate daily measurement of weight is important. Laboratory tests that most accurately reflect the therapeutic effects of TPN are serum albumin and nitrogen balance estimates. If TPN is effective, serum albumin should either be stable or increase toward normal levels, unless some clinical condition such as fluid retention or liver disease is affecting albumin concentration. Nitrogen estimates should show the patient to be in positive nitrogen balance throughout therapy. If therapeutic responses in terms of weight, serum albumin level, and positive nitrogen balance are not apparent within 21 days, then the TPN therapy isn't working and a new regimen is indicated. To review, comprehensive baseline data is needed before starting TPN therapy in order to provide for accurate monitoring of the patient's status. While the body is adjusting to TPN therapy, daily measurements are taken of body weight, intake and output, nitrogen, electrolytes, and glucose. After the patient's response to TPN therapy has stabilized, tests of albumin, liver enzymes, and triglycerides are done weekly, while electrolytes and creatinine are generally checked twice a week. The metabolic response of the patient to TPN and the pathophysiology that requires its use changes as the patient's condition changes. This can alter TPN requirements and can lead to complications unless the nurse is alert to the prevention, detection, and treatment of metabolic complications. Metabolic complications arising in response to TPN may be caused by either an impaired capacity to tolerate nutrient loads or may be a direct byproduct of specific physiological responses. One common complication is hyponatremia or hypernatremia, too little or too much sodium in the blood, which may be caused by fluid excess or deficiency. Daily weights, accurate measurement of intake and output, and observation of tissue hydration will quickly detect such a fluid imbalance. To prevent fluid excess or deficit, the designated flow rate of the TPN solution must be maintained constantly, and any unusual fluid loss due to diarrhea, diaphoresis, drainage, or diuresis must be carefully replaced. Any change in serum sodium levels is likely also to affect chloride and potassium ions and the acid-base balance. Close monitoring of serum electrolytes will detect these potential or actual imbalances. And careful monitoring of the amount of chloride given in combination with sodium or potassium as electrolyte additives can prevent excessive serum levels of this electrolyte. Usually, 1/3 of the total sodium and potassium additives is given as an acetate rather than as a chloride in order to maintain the acid-base balance as well as an equilibrium of electrolytes. Low magnesium concentrations are mainly a problem when the patient has excessive gastrointestinal fluid loss. So careful monitoring and replacement therapy is essential for these patients. A phosphate shift occurs predictably when high concentrations of dextrose are administered parenterally. Phosphate additives can correct this deficiency, but if too much phosphate is added to the TPN solution, precipitation of insoluble salts can occur, so the nurse must be careful to check for precipitants before administering the solution. A less predictable metabolic complication is hyperglycemia. While the patient may initially need to have insulin added to the TPN solution in order to handle the concentrated dextrose solutions, adaptive mechanisms may gradually allow him to tolerate higher glucose loads without exogenous insulin. It is advisable to administer concentrated dextrose solutions in gradually increasing quantities so that patients who might have trouble handling the sugar load be given time to adjust. Since glucose metabolism can vary from time to time, it is essential that the nurse monitor blood glucose levels routinely, usually every 6 hours, and be prepared to provide insulin coverage or reduction of insulin additives as indicated. To review, major metabolic complications of TPN administration are associated with fluid load, electrolyte balance, and glucose levels. Close monitoring of blood tests will detect these complications in their early stages. Careful monitoring of TPN additives, together with analysis of trends in blood tests, will frequently prevent these complications from occurring. Judicious alteration of the composition of the TPN solution remains the major form of treatment when there is no underlying pathology causing the complication. Catheter-related problems such as infection can also cause metabolic abnormalities. Mild hyperglycemia may be an early sign of developing infection in a patient who has previously been running normal blood glucose levels. If hyperglycemia is accompanied by fever, chills, diaphoresis, drowsiness, or weakness, the nurse should suspect an infection in the catheter itself. Infection at the catheter exit site is accompanied by redness, swelling, tenderness, skin irritation, and drainage. Infection is one of the major unpredictable complications of TPN, but it can be prevented by closely following strict aseptic technique in all procedures. The catheter hub has been identified as the major source of catheter sepsis, so the less manipulation of the hub, the less the chance for infection. However, routine changes of the administration set and flushing of the catheter are necessary, so some manipulation is unavoidable. To minimize bacterial growth at the catheter hub, it is necessary to observe strict aseptic technique when interrupting the integrity of the TPN line. Although contaminated solutions are rare, the nurse should carefully examine all containers for cracks or punctures before connecting them, and should check the solution for clarity and turbidity before use. The potential for bacterial growth increases with the length of time of the infusion, so no bag of solution should be used for more than 12 hours per 1,000 milliliters. If catheter infection is suspected, a blood culture should be taken. The administration set and solution should be replaced. The distal end of the administration set that was removed should be protected, and the entire set with the solution container should be sent to the lab for culture. If blood cultures do confirm the presence of sepsis, some physicians recommend removal of the catheter. Infection of the catheter exit site is a serious complication because the infection could ascend through the catheter tunnel. Since antibiotics usually cannot eradicate a tunnel infection, removal of the catheter would be necessary. Recently, an antimicrobial catheter cuff has been developed that provides a slow-release antimicrobic agent over a 4 to 6 week period of time. Since the exit site heals within 2 to 3 weeks, providing a seal around the catheter cuff, tunnel infections are now relatively rare. However, while the exit wound is healing, meticulous attention to aseptic technique during dressing changes remains the best form of protection against exit site infection. To review, infection is a major complication of long-term indwelling catheters. Infections can occur in the catheter itself or at the exit site. Infection at both sites can be prevented by maintaining strict aseptic technique when handling any part of the TPN setup. This includes making certain that the solution is infection-free, changing the administration set aseptically, flushing or irrigating the catheter aseptically, or using aseptic technique when changing the dressing. Although central venous catheters can generally be used for many years without the development of complications, there are potential problems that must be considered when caring for the patient receiving long-term TPN. Continuous, uninterrupted infusion of TPN solution, together with periodic flushing of the catheter, will generally prevent the formation of fibrin or clots that might block the tubing. However, a fibrin sheath may form at the tip of the catheter. Or, if blood is allowed to back up into the catheter, a clot may form. In either case, blockage of the catheter may occur. Blockage of the catheter may also be caused by cracked connectors or kinks in the tubing. If there is an unexplainable slowing of the infusion rate, the nurse should check the line for kinks, have the patient change positions, move his arms, and rotate his head. If the infusion rate remains slow, the pump should be turned off at once, and the catheter should be irrigated with the prescribed heparin solution. If resistance to the irrigation is felt, and the infusion is allowed to continue despite the blockage, pressure could build up through the infusion pump and cause a break in the connections. The catheter should be clamped. And orders secured for further treatment. Blockage due to fibrin clots and thrombi can be treated with a thrombolytic agent. The agent, usually streptokinase, 10,000 units in 3 milliliters of saline, is instilled into the catheter and allowed to remain for 5 to 10 minutes. The solution is then aspirated, and the catheter is irrigated thoroughly. These steps can be repeated 3 times if the blockage is not released by the initial applications. Remember, force should never be used when irrigating a catheter. If the blockage is caused by a clot or thrombus, force could dislodge it, creating an embolus. Air emboli are preventable by maintaining the integrity of the TPN line and by taking proper precautions when the integrity of the line must be interrupted. Before the patient moves from a flat to an upright position, the nurse should check that all line connections are tight and that there are no breaks in the line or catheter. The patient is at highest risk for an air embolus when in an upright position, so the patient should be placed in a supine position when the administration set or solution is changed. Have the patient perform a Valsalva maneuver when the catheter tip is open to the air. This will increase the intra-abdominal pressure on the vena cava and prevent air from entering the catheter. Be certain to use infusion pumps with inline air detectors. If lipids are piggybacked, then add the piggyback above the pump's air device using a 15-gauge needle or quick lock set. Whether the result of a thromboembolism or an air embolism, the presence of an embolus in the bloodstream is an emergency situation. Symptoms of tachypnea, tachycardia, chest pain, vertigo, or confusion indicate the possibility of an embolus. The patient should be positioned on the left side in Trendelenburg position so that the pulmonary artery is below the right ventricle. He may also be given 100% oxygen by mask until the physician arrives. An air embolus is 80% nitrogen. By decreasing nitrogen levels in the alveoli, oxygen helps decrease the size of the embolus. To review, the most common occurrence of air embolism is during solution or set changes, or inadvertent disconnection with the patient when in an upright position. Always occlude the catheter with a clamp when opening the setup. Have the patient lie flat in bed and perform the Valsalva maneuver when the set is open. Do not forcibly irrigate the catheter when blocked. Other problems that may occur with the central venous catheter include breaks or tears and dislodgement, although these are rare occurrences. Generally, a break or tear is noticed as soon as it occurs. But sometimes the first indication is leakage of TPN solution. If a break or tear occurs, the catheter should be clamped between the break and the exit site. The catheter should then be repaired using the repair kit and instructions supplied by the manufacturer. Breaks and tears can be prevented by using care when handling the catheter, that is, by not pulling or twisting the catheter sharply. Using a needle carefully when flushing the catheter or instilling fluid will prevent inadvertent punctures. When using a clamp, the nurse should be certain that the clamp has no sharp edges and that the catheter is clamped at a different spot each time. The most common causes of dislodgement of a central line is severe coughing or vomiting or physical stress on the catheter. The loose end of the catheter is generally taped to the chest to avoid pulling or stress. Since the patient's coughing or vomiting often cannot be prevented, the nurse must be alert to signs of catheter dislodgement if severe coughing or vomiting does occur. If the patient complains of pain or discomfort with the infusion, or if there is swelling in the arm, neck, or chest wall during the infusion, the catheter should be checked for blood return. If there is no return, the catheter should be heparinized and capped. A chest X-ray should be done immediately to determine the position of the catheter. If it is dislodged, the catheter will have to be removed immediately. To review, if the central venous catheter should become broken or torn, it should be clamped immediately and repaired. A dislodged catheter is detected by close attention to patient's symptoms. If there is pain, discomfort, or swelling, the catheter is heparinized and capped immediately. If X-rays confirm dislodgement, the catheter is removed. Part 2 has presented the physiological parameters used to monitor the status of the patient receiving TPN, and has explored the prevention, detection, and treatment of both metabolic complications and catheter-related problems. The nurse, through meticulous attention to these details, can ensure that the lifeline of TPN is maintained safely and effectively.